Welcome everybody to the Three Skills Mental Health Programme seminar. Today we have the pleasure of Carolyn Graham, Tom Kingstone and Tamsin Fisher, who are going to be discussing how can we improve the mental health of older adults. And the session will be recorded and saved on the Three Skills website after. So without further ado, I'll hand over to the team.
Thank you so much, Claire. So please forgive me because I've got a hoarse voice because I've got a respiratory infection, so I apologise in advance. So we're going to talk about the mental health of older adults. And I think we see a lot in the news about the mental health of children, which is really important. But actually here at Keele, we've been focusing very much on older adults who are perhaps an underserved and forgotten group. So the aim of this seminar today is we're going to set the scene. We're going to describe some key studies that we've conducted at Keele. Think about next steps, the implications, impact of our studies, and impacts for policy and practice. So what you need to know about older adults' mental health. So on this slide, we're talking about people over the age of 50, but you'll note that we've also got some points in about people over 50. So 65, 50, and we'll come to this in the next slide. There is a bit of discussion about where older adults sit and where it starts, and I think it depends on which side of 50 you're on. Anyway, 11 million people, that's 18% of the population, are over the age of 65. Rural areas are ageing faster than urban areas, so people move out into the country and they grow old in rural areas which have got poor transport links, poor digital links. We know that people over the age of 65 have long-term conditions, multi-morbidity, multiple long-term conditions. I'm sure we've heard a lot about the winter heating allowance, but we know that 2 million people who are on a pension live in poverty, and 2 million people have homes that do not meet basic requirements in terms of cold, damp, ventilation. We also know that loneliness is a key problem in older adults, although to be fair, loneliness is a problem across the age range. And there's some recent evidence that loneliness is the new smoking. So loneliness and social isolation have a really detrimental effect on people's health, mental and physical. We know that people over the age of 50 are often likely to be unpaid carers, and it may be for their partner or for parents or occasionally for children. And as I've mentioned already, digital exclusion is a problem for some older adults, but particularly those who live in rural areas. We tend to think of older adults as fairly non-ethnically diverse, but that's changing, and that's changing particularly in inner city areas where we've got extended families. Okay, so why are we thinking about older adults, and what do we mean by older adults? Is it over the age of 60? Is it over the age of 50? Is it over the age of 65? It's a contested term, and we tend to, in our work at Keele, go with the World Health Organization of it's over 60, but we do tend to change depending on the study, don't we? Okay. Common mental health problems are common in older adults, so anxiety and depression. Probably about 1 in 4 older adults might have an anxiety symptoms or depressive symptoms, but they don't seek help. They don't seek help in the same way as younger people. I'm speaking as a GP. They may come in asking for a tonic, or they may come in with physical symptoms. They may not seek help because they don't recognise that there's a problem to be addressed. They may think that it's normal to feel a bit miserable or a bit anxious or a bit stressed. And healthcare professionals also normalise those feelings. Well, of course, that person's in pain, so they're going to be distressed, or they've got diabetes and diabetic neuropathy. Of course, they're going to be depressed or anxious. And there's lots of barriers that prevent older adults seeking help, whether it's stigma and lack of awareness in themselves, whether it's because they wish to maintain their independence and worry that actually if they seek help, they might be put into a home. But also there are barriers at system level. So people may not be able to negotiate the online query system that operates in most general practices. They may go to a GP and not feel it's right to present mental health symptoms, so present physical health problems. And as I said, the practitioners may not pick up on somebody over the age of 60 who's got anxiety and depression and may normalise those symptoms. So, what's needed? We also know that when somebody has mental health problems, that they can refer to NHS Talking Therapies. But we know that older adults, and for this we use 65 plus, they are underrepresented in NHS Talking Therapies. So compared to 16% of the population, only 5 to 7% of referrals of older adults. And they're predominantly female, they're predominantly white British, they're predominantly middle class. So why do people not opt in? Why do older adults not opt into talking therapies? Well, they may think it doesn't work, or I don't know what they're going to offer, or it's not for me, I don't do talking. They may not feel that the offer is culturally acceptable. They may actually not be able to self-refer. You've got to be able to use the app. You've got to be able to refer yourself in. You've got to be able to receive text messages. So if you've not got a smartphone, you're stuck. And it's quite an informal, impersonal and sort of confusing process. So the loss of the sort of GP referral into talking therapies, I think, has differentially affected some groups of people, including older adults. But there are other alternatives. So social prescribing has been set up to meet the needs of people like older adults who've got psychosocial needs. But again, the evidence is that it's not reaching those people with the greatest social needs. Often what's on offer is a digital mental health intervention, so computerised CBT. Again, if you're not digitally literate, if you've not got a smartphone, you can't use that. And what we think, what the evidence suggests, is that actually, rather than medicalising people's anxiety and depression, we should be thinking more of non-medical, non-clinical, more community-based approaches, linking in with social prescribing, linking in with community organisations that are already existing in our communities.
Okay. So through our research, we're focusing on kind of three kind of targets or missions, I suppose. So first is to help improve the inclusivity of existing interventions. So by this, I mean kind of enhancing the acceptability of existing interventions, but also the willingness amongst older adults to engage with these services and offers, really, because many do work, as some of the evidence suggests. Second, to help build capacity and capability within the wider system to deliver and or signpost to evidence-based interventions. There's lots of opportunities out there to support some of this help-seeking, these help-seeking behaviours and attitudes towards help-seeking. So it's about improving kind of capacity and capability to do that. And then thirdly, to help grow the evidence base for new interventions that address unmet needs and preferences, particularly of those marginalised and underserved groups that Carolyn's been mentioning already. And much of our research has been underpinned by kind of 4 ideas or assumptions. So the first being kind of early interventions crucial in order to alleviate suffering, but also prevent future crisis. Second, that we recognise that older adults may already be engaging with individuals, organisations and services, which may or may not be linked to mental health or wellbeing. But these points of contact offer potential opportunities to provide some mental health support, whether that's through kind of motivational nudges or information and building kind of awareness. So we think it's important to kind of be resourceful in this space and optimise some of these points of contact. Thirdly, that we focused on enablement and promoting independence rather than pathologizing mood and projecting kind of vulnerability onto older adults. So really taking a strength-based approach, not deficit kind of defined. And lastly, we recognise the need to apply obviously an intersectional lens, building on what Carolyn said in one of the earlier slides, really appreciating the different barriers that older adults face based not only on age and ageism, but also gender, disability, ethnicity and socioeconomic kind of status. Older adults are too often defined and treated as a homogenous group, and we need to kind of overcome that, really. Next slide. Thanks. So we're going to talk through mainly 3 studies that we've been developing and have undertaken in this area. So the first is our Riddle study. So this was a realist review of current literature around interventions to detect and manage depression with or without anxiety, delivered by non-traditional services. So the term non-traditional has been used in various different kind of ways. For example, it could have been used for spiritual healers and things like that in other research. But in our research, we focused mainly on public services that did not traditionally deliver kind of health and social care. So our particular examples focus mainly on the police and fire and rescue service. Then we'll talk about Fireside, which takes learning from Riddle and explores in more depth the potential role of the fire and rescue service and the acceptability of the fire and rescue service in providing some type of mental health support to older adults. And then finally, we'll talk about Shadow, which is another realist review of current evidence, which takes a bit of a narrower focus on help-seeking processes and trying to understand how these are activated in mental health interventions. And just a note to self, we did really well with our acronyms, but not so good with our logos. So that's something we need to improve going forward. Okay, so yeah, so starting with Riddle, yeah, and you can click through, thanks. So Riddle was a realist review of interventions that seek to identify and or manage depression delivered by non-traditional providers and older adults in the community. So first off, we're going to talk about a couple of realist reviews. So just in terms of, I'm not going to provide any methodological insight into what realist reviews are, just use the kind of basic overview, I suppose. So these approaches, these reviews applied a systematic approach to reviewing existing literature. And while systematic reviews look at intervention effectiveness, whether something works or not, realist reviews take a bit of a deeper look to look at how, for why, for whom, why, and in what circumstances things work. So you can imagine kind of a car, I suppose you want to look under the bonnet and see how the mechanics of that kind of car works. And that's the same kind of logic that we'd apply to intervention design and how they kind of work and function, with the aim to develop some kind of explanatory theory that helps to explain some of the complexity and all of those kind of little dimensions there, the how, why, for whom, and in what circumstances, and the contextual kind of stuff, really. We apply 5 steps to our realist reviews. So following all published kind of guidance on these things. So we start with an early scoping review and some consultation with stakeholders. From there, we produce some kind of candidate theory, so some early kind of ideas and explanatory kind of statements to understand why and how and for whom these kind of things work. Follow this with a systematic literature search and appraisal of the existing evidence. Extract the kind of key data that's relevant to those initial kind of candidate theories and help build on our understanding. And then we provide some kind of theoretical statement or model that helps, again, to advance that understanding of those candidate theories and provide this kind of theory of how these kind of things work and function. Okay, so in terms of our approach, so what did we find? So that initial kind of scoping of the literature identified that actually there aren't really any mental health interventions delivered by these non-traditional providers, focusing on kind of police and fire and rescue service. We're not related to kind of the mental health problems we were focusing on, so anxiety and depression. So we broadened our kind of scope quite early on to focus more broadly on health and well-being interventions that were delivered. And then we kind of did our systematic search based on those, identified 15 key papers and did some cluster searching around those papers to identify additional references. You can see in the nice kind of colourful diagram there, those are the larger kind of circles, those are our 15 kind of key papers, and then all of those other papers are found through kind of our cluster searching. And you can see how a lot of the kind of literature speaks to other parts of literature, whereas some kind of sit alone and don't really engage or build on some of that kind of literature. In terms of the evidence that we identified, there were lots of different interventions delivered by the fire service and police. Some of those examples from the fire service were in relation to falls prevention, smoking cessation, bowel cancer screening. And for the police, it was more around kind of custody processes. So thinking about how potential perpetrators of crime, how they present in custody in terms of mental health crises. So the kind of the more severe end of the scale that we weren't so much kind of interested in, and also thinking about kind of victims of crime and how how they present mental health problems and issues. Worth saying as well, predominantly a lot of this evidence we identified was at a service evaluation kind of level, and kind of lacked research kind of methodological kind of rigor. Next slide. So just to we found a lot, so I'm not going to go through all of that. I'll just kind of summarize a few kind of key points really. So what we came up with in the end, this kind of multi-level kind of model or idea as to how these kind of interventions worked. So thinking about kind of the individual level for older adults, whether they engaged with an intervention or not seemed based primarily on this perception of risk. So we can take kind of the risk of falls, for example. So how real did this threat seem to older adults involved in these initiatives and interventions? And this sense of risk was then kind of offset against the potential that any intervention had to impact or limit their kind of sense of independence and autonomy. So would admitting they needed help for falls prevention, would that kind of support or highlight other vulnerabilities and then reduce this kind of sense of autonomy in their kind of lives? And at the point, moving on and level, at the point of kind of interaction between older adults and non-traditional service providers, we noticed that trust was key, but also had kind of boundaries and limits. So people from the fire and rescue service, for instance, were often well regarded and respected, and this trust allowed them to gain entry into older adults' homes. So there was trust in the uniform, trust in the badge. But this trust didn't automatically extend to topics that were not directly seen as relevant to the fire and rescue service and their role and their professional status. So things like health and well-being felt a little bit out of bounds for older adults, and also for for fire and rescue service professionals as well. So trust needed to be continually earned and demonstrated in order for non-traditional providers to be seen as having legitimacy in this kind of space around mental health or health and well-being in this context. And then just briefly, the other kind of two levels. So interventions seem to work best when there was flexibility built into the intervention and the scope of the intervention. So giving space during kind of the meeting, the contact kind of points, giving space to explore with older adults what they're already doing to maintain their well-being and kind of building on those kind of strengths. And then finally, at this kind of integration at kind of service level, it was essential obviously to engage with and integrate interventions into existing kind of care pathways. But there was importance in terms of kind of mutually respectful linkage between traditional and non-traditional providers. This was seen as important, and this integration could be quite subtle and could be subtly reinforced through kind of things like some kind of social artifacts, if you like, so co-badging resources that were shared with older adults, which showed there was a clear connection between, let's say, the NHS and the fire and rescue service, or the fire and rescue service professionals being trained by senior clinicians, that kind of thing. All these kind of levels of endorsement really, and this kind of artifacts of collaboration really helped these interventions to function. And then we took these ideas and this kind of program theory forward into our fireside study. I'll nicely hand over to Tamsin.
Thank you. Oh, I didn't realise there were more arrows, so I'm clicking through. Apologies.
Oh,
there we go. I didn't realise there were more arrows. Yeah, so fireside study, as Tom said, this was about working, or sort of understanding, could the fire and rescue service be utilised to detect and signpost anxiety and depression in older adults? This is through their home fire safety visits. I think they used to be called Safe and Well. The current name is home fire safety visits. So just in case I do flip between the two terms. So in case you're not aware of what they are, these are home safety visits. These are completely free, and there's an eligibility criteria. So if you're over the age of 60, I believe if you do have children living in the home, or if there's anybody living in the home with a disability, you are eligible for a home fire safety visit. You can go to visit your local fire service website, and you can make a referral or self-refer, or you may be referred as well by a health or social care professional. Couple of 23 to 2024, they completed just shy of 600,000 visits across the UK. That's the 24-25 are just about to come out, so sorry they're a little bit out of date, but they'll be around about the same numbers. It's generally around that 5 to 600,000 mark that they aim for. And these involved a general safety check of the home. So they might check, are you overloading plug sockets? Is there evidence of a chip pan? Electric blankets? What types of fire are you using? but also if people have oxygen as well. So particularly patients with COPD, the fire service will do, I think it's annual or biannual checks of the home. They'll also install smoke detectors and equipment completely free of charge, but they also include some lifestyle questions, so around finance, and there is one question about mental health on the form, and I'll talk about that in a moment. These visits last anywhere from 20 minutes to 2 hours. It completely depends on the needs of the constituent of the homeowner, and also how chatty they are. So I was very lucky to be able to go out. We were working with Staffordshire Fire and Rescue Service. We interviewed older adults who'd received these home fire safety visits, but also health and social care professionals who may or may not have been working with the fire service, or at least were aware of the home fire safety visits, as well as fire and rescue service staff who are conducting these visits. I was fortunate enough to be invited out to observe some of these home fire safety visits to understand what was going on, where could an intervention fit, how do older people respond to the fire service. And ultimately, we took all of our data to a workshop that we hosted at the Staffordshire Fire HQ. We invited, again, older adults, fire and rescue service staff and health and social care professionals, where we began to think about developing a blueprint for an intervention. So this is just an outline here of what this home fire safety visit looks like, and a bit of a timeline. Again, as I said, this is 20 minutes up to 2 hours, give or take. So it's arrival and introductions. The fire people, the fire service, they then outline the purpose of the visit, what they're going to do, lay out some expectations. Then they sit down with the recipient. In the case of the observations, this was specifically with older adults, and they'll ask questions about the individual. Are they in the right place for a start? Have circumstances changed? So, for example, one of the visits that I did, it was a repeat visit, and the lady that was living in the home, her hearing impairment had become a lot more advanced than before, so she needed some new equipment. But also the reason was for the visit was that her husband had a fall, so that their circumstances had changed basically. So it was just understanding what's going on. Then they'll do a check of the property, as I said, checking plug sockets, making sure that fire smoke alarms are working, equipment is working as needed. And then they'll sit down again, do a safety talk, action plan. Is it a stay put policy, or are people able to climb out of a window? Majority of the time with the older adults, it's please don't climb out of the window, go out the front door, but it's just making sure people know what they're doing. And it's in that safety check around the property that we identified there's potential for some form of intervention with the older adults in terms of sort of raising awareness about mental health, anxiety, depression, low mood, maybe a little bit loneliness as well. And this is where we could offer potentially a video or some reading materials, depending on what the older adult would prefer. And we've developed something with our patient advisory group, and I'll share the video with you in a moment. But just some of the findings from some of the visits that we did and some of the interviews, time and time again, we heard the phrase, the fire service are a foot in the door. They have access to properties that a lot of health and social care professionals don't, particularly social services. Social services are a consent-only service, which means that they're not allowed in the property if somebody denies them access. So working with the fire service, sometimes they would go along with the fire service in order to gain access to the property. As Tom mentioned, the fire service are very trusted. So if the fire service also trusts social services, the older person is more accepting of social services being involved in their care. But also the fire service are, again, using quotes from the interviews we did, where they were eyes on the ground. Particularly in the wake of the pandemic, a lot of services have remained either online or over the telephone, whereas these home fire safety visits can't be done on the telephone. They need to physically see what's going on. So they are physically in the property, they are eyes on the ground. The community matron here, she summed it up really well and just said that it's all the services over the phone, and a lot of the elderly population aren't happy to talk on the phone. They want to see someone face to face, and I think the fact that somebody's there with them, showing them the time, this could be really good. And for others, it wasn't necessarily about, is it acceptable for the fire service to support older adults or potentially be there to identify anxiety and depression, but it was expected. Somebody talked about, their fire service, they're working in a caring profession, in a caring role, and actually you'd hope that they'd want to make a difference in some way, shape or form. However, at the moment, they don't receive any training or awareness training around what to look out for in mental health in their constituents, in the local population. And this is just a quote from one of our focus groups. She said about, I've had a few incidents where mental health has taken over and I don't know how to deal with it. I haven't got a clue what to say, and I don't know what is the right thing to say. How are you supposed to identify what the right thing to say is? We're not trained on that, and we're not specialists. We go in and we ask the questions, and one of the questions on our form is, in the fire safety visits, is, are you depressed? But if they say yes, what do I say? And this is where we're looking at developing some sort of intervention, sort of mental health awareness training for the fire service. So I'm hoping that the technology is going to work. So this is the video that we've produced with our patient advisory group and also off the back of our co-design workshops. I'm hoping, can you hear the sound? So that's been a while since I've seen that video, so it's quite nice to see it, to revisit it again. But I've missed Jean. Yeah, so these co-design workshops, again, we worked to come up with ideas for the video and some of the messages for older adults. And these are just some of the messages, and we'll share the slides with you. But just very quickly, it was around that the fire and rescue service are there to help, encouraging confidence and independence in older people, that it's okay to not feel okay, and that the fire service can listen with empathy. They maybe have the time that other services don't always have. They might kick me for saying that, but from what we observe, you know, they did have the time to sit down, and they wanted to make the time to sit down and listen to people as well. They can also encourage informed choices. So again, that could come down to if people aren't quite sure what to do, the fire service can sit with them and help them make those decisions and come up with ideas of where they could get help, and also understanding support networks could look like. And then in terms of the training itself, that I'll pass over to Tom about that shortly. But the training that we came up with three key objectives for the training that will be developed for fire and rescue service staff. And this was just starting at the beginning of just an awareness of mental health, anxiety, depression, particularly in older people. What does that look like? Encouraging and enabling staff to feel that they can talk confidently about mental health. That's both asking the questions, but also receiving the answers and knowing how to handle that and knowing what to do, where to go, and being able to identify those risks. And this is where I'm going to pass over to Tom to talk about Fireside 2.
Thanks, Tamsin. Yeah, so we're excited to announce that 3 schools have approved funding for the next stage of Fireside. So we're going to be conducting Fireside 2, where we're looking to deliver a fire and rescue service-led intervention to facilitate help seeking for anxiety and depression in community dwelling older adults. So building on all of that work that Tamsin's nicely explained. So this will be an 18-month study, looking to finalise the co-design of those intervention materials that were highlighted in those visuals, and then we'll be looking to work with 2 case study sites in Shropshire and Derbyshire to roll out and train up fire and rescue service personnel, and then see how this intervention goes in those kind of case study sites, looking at a mixed methods evaluation, covering a lot of different kind of aspects and dimensions, really, in terms of outcomes for the quality of training and the increases in kind of knowledge and confidence around mental health. And then for older adults, thinking about kind of mental health literacy, addressing some of the stigma and help seeking barriers and things. And then in terms of processes, looking at the fidelity of the intervention that we've designed, and then the level of kind of engagement with it. And then also doing a cost analysis of that as well, to try and understand how sustainable this might be in the future, and what other access to or leverage of financial support might be needed for fire and rescue services to take this on. So in terms of the kind of impact this will generate, or we'll develop all of these resources. So we'll have this kind of signposting kind of toolkit really, and we'll have these training manuals available for national implementation, and we're working closely with the National Fire Chiefs Council to enable this going forward. Back to you, Tamsin.
Yes, so off the back of both Riddle and Shadow, we then moved into another study that we call Shadow. And this was a realist review of interventions that help facilitate help seeking for anxiety and depression among community dwelling older adults. So again, age 60, older adults defined age 60 plus in this study. And we defined help seeking as this action of actively searching for help from others via formal or informal mechanisms. So that could be family, friends, neighbours, but it could also be health or social care professionals as well, or maybe even community leaders, community organisations. With older people, there's often sometimes this reluctance to seek help, and this is predominantly around the recurring theme around stigma, around accessing help, but also about this need to maintain independence. And Tom alluded to it earlier about if people disclose that they're struggling, or they feel that they are feeling low, that there is something not quite right, is will I get put in a home if I tell my family that I'm not feeling myself? So this project was about understanding how best to help facilitate that help seeking and improve the uptake of existing resources to align with the prevention agenda. So it's not about recreating the wheel, it's not about developing a brand new shiny intervention. It was what already exists, how are people working with it, and how do they need to be adapted to improve or increase the number of people seeking help. And ultimately we came up a little mini equation for you here. The only quantitative data I will ever work with is the attitude and intention equals behaviour. And that led us really nicely into thinking about sort of the three key themes and three steps, I suppose, in the process of help seeking in older people that we identified through this review. And the first being sort of non-help seeking. And our patient advisory group come up with a really great analogy of the toolbox, and thinking about in terms of your mental health. And the non-help seeking is where the toolbox is, you've got this toolbox, you've got these tools in your box that you're using to cope with everyday life, to try and manage that anxiety, manage depression, manage any loneliness. But at some point we reach a tipping point and that toolbox becomes depleted. The tools are either gone missing, they're no longer working, they're broken. And actually that's when people then maybe realised, I need some help. I need to refresh the tools in my toolbox. And this is where we look at not just recognising the need for help, but then the accepting of help as well. So these were just some of the messages that came through from the data. Under the non-help seeking, it was about this need to maintain independence, this self-reliance, the avoidance of help, ultimately coming down to stigma and wanting to maintain this positive identity to the outside world, and concealing mental ill health from others, but also from themselves, whether that was conscious or unconscious. For some older people, it's that they don't necessarily understand what mental ill health is. I think from those interviews that I've done, especially over the last couple of years, this real, it's only mental health if you're really, really poorly, they're thinking sort of almost going down the severe mental ill health route, but that's not necessarily the case. We hear the time and time again this normalization of it's just normal to feel low when you get this old, or it's normal to worry this much as you get older. That's not necessarily normal. There is a tipping point of when it's no longer normal and if it's affecting their everyday life. And that's when we go into those tipping points, and that internal capacity for coping with every day and managing your anxiety and depression becomes exposed, and they recognise that there is a need for help. They may be made aware of the scale of their ill health by family members or friends who recognise that, the house has, like Jean, the house, it was getting on top of her, or maybe a health professional has noticed a decline. But for some people, particularly those the studies that we identified that were working with minority ethnic communities, there was this moral obligation for families to look after the older generation. And actually, sometimes some of the cultural stigmas and cultural barriers were another challenge to getting that help. And it was the stigma wasn't just from the older person themselves, but also the family, and not wanting to expose that there was a quote problem, and therefore seeking help became a bit of a challenge. Mental health services, when people did get help, it was often mental health services were offered in formats that were familiar to the older person. So whether that was, for example, through peer educator schemes or befriending schemes, these particularly were quite popular and did have quite quite a positive outcome, in the sense that a lot of people, the older people, felt valued and heard. They felt that they could speak to people that were like them, that were the same generation as them, and therefore they felt that they weren't different, and that it wasn't normal, but it was also normal to feel this way, and others also felt like that. They didn't feel alone. And it was often came down to that offer of social engagement or relationship. All that being said, though, it was not just not help seeking, tipping points, help seeking. A lot of the older people that in the interventions we looked at, it's not a linear process, and it would flick between not help seeking, tipping points, help seeking, not help seeking. It was the help seeking process is hard work, not just for the older person, but for the family and friends supporting them, and the health and social care professionals trying to encourage them to engage as well. So we worked with our patient advisory group. Again, they've been absolutely fantastic across all of our projects. And we've developed a series of characters. This is just one of the characters. I think we've got 4, and they'll be available on our website shortly. So I think Tilly's already on there, but we've got our others to add as well. And this was just a fictitious character, but again, it's hopefully a resource that we can share with older people to help them encourage seeking help and help them see that, they're not alone. Others do feel like this too. So fictitious character, but I'm sure many people can relate to Tilly here. So Tilly lives on her own, and her grandchildren are just not visiting her as often as they used to. She's struggling to keep on top of her housework, and she's finding it difficult to get out and about. She's feeling quite sad and quite lonely. She's embarrassed to tell her friends that her grandchildren don't visit very often. She doesn't want to burden others, and she doesn't think others want to hear about her problems. But Tilly's just not coping. The house is dragging her down, and one of her older adult children visits and notices that she's just sad and fed up and not herself, and suggests that it's time to get some help. Tilly admits that she is struggling and that she is lonely, and agrees to contact the GP, who suggests that a social prescriber might be able to offer some help and support. An occupational therapist is also contacted to help with adaptations that she needs around the house. She's offered antidepressants, but decides that's not for her and engages with the social prescriber. So, as I said, we've got other characters as well who we can share at a later date if you want to.
Brilliant. Okay, thank you. Really, I think, although I'm biased, really good summary of all the work so far. We have another study which is starting this week, actually, and I think Joe's here now, Joe Durrant. We've got a PhD study funded by Keele Legacy Funding. And we're going to take forward this work to think about an intervention to support help seeking for older adults living in rural areas. I won't go through all the objectives, and obviously it's the beginning of the PhD, so things might change. We're going to be flexible. Next slide, please. Okay, so we've done a lot of work. Are there any implications? Have we achieved any impact? So there are implications that we feel that we should be targeting the 5 in 6 older adults who have symptoms which may represent mental health problems, certainly might have symptoms, and it may be affecting function, but they're not actually accessing services. And what the approach that we always try to take and want to take in future studies is a strengths-based approach. We want to avoid medicalisation and medication, because we know that older adults don't necessarily want medication, and there's a risk of polypharmacy. So we want to approach things with a sort of patient or person enablement. So our work has been exploratory so far, developmental. Riddle and Fireside have informed intervention development, and Fireside 2, we will take that forward. We think that non-traditional providers, and if you can think of another better term than non-traditional, we think they're really important. They do a lot of work already. Community organisations exist that may be underused by primary care. Social prescribing may address that. We don't always know what they're doing, whether what they're doing is evidence-based, so we want to take that work forward. And as Tamsin and Tom have explained, Shadows clarified our thinking around help seeking and what are the barriers to help seeking, in particular, where the tipping point is. So what next? We've said already, Fireside 2, PhD studentship, and probably more grant applications, so look out for those, Claire. These are our outputs, and you'll be able to see those when you get the slides set, so please do have a look at them. You can also see the animation. And lots of acknowledgements, obviously the funders. Big thank you to Katie Tempest, who was a member of the Keele Research User Group, who was fundamental in the early work that Tom and I did around older adults, and unfortunately died, but has left a really great legacy, I think, and that's been taken forward by Jane and Samina. We have really active public advisory groups, and thanks to Anna Huff from Keele Research User Group. And yeah, the usual disclaimer that the views that are expressed are ours and from our studies, and not necessarily those of NHR. And I think that's probably it. Any questions? Tamsin, I don't know if you want to unshare, and then we can see if anybody's going to put hands up or put anything in the chat.
Anything
Or
from the
everybody's
floor at all? I've got one we could start us off with, Carolyn. How receptive do you think the fire and rescue staff will generally be to asking about mental health?
I'm going to put that over to Tamsin, because you were obviously with them with your ethnographic work.
Yeah, so I think in general the older adults really responded very well to what the fire service more generally. The way that they build rapport is fantastic. I've got so many anecdotes I could share. I loved doing the observations, they were great. But in terms of the mental health question, I think it very much depends on how the question is delivered. So for example, on the observations that I did, some of the personnel would just ask outright, so have you got any depression? No, off you go. How do you use a chip pan? So the way that it's approached, people are not going to go, do you know what, actually, yes, I am really struggling. But if it's approached in a slightly more gentle way of, how are you coping? You know, have you got support? One of the questions that I'm really surprised by during the observations was, have you got anybody to take your bins out? Or how do you get your bins out? Is everything all right? And I think, what's bins got anything to do with it? But what they're actually asking is, do you have family and friends? But if you say the question, do you have family and friends? Are you lonely? Are you on your own? People are going to go, oh no, I'm fine. But if you say, who takes your bins out? They'll go, oh, my neighbour does, or oh, my son comes over, and immediately you find out. So it's just the way that you approach the question. I think so long as it's approached sensitively and carefully, I do think it will be okay.
Will there be any training for them at all to develop how they actually speak to folk?
Yeah, so part of the training practice we're putting together with Fireside 2 will cover that, and that developing the conversation management, is that the way of putting it, or the communication, I suppose, just working out what's best to do it. We don't know what that will look like exactly yet, but I think from the workshops that we did, it was suggested about little role plays, whether that's through videos or practicing with each other in the training itself.
Brilliant. I think looks like Lydia Morris has got a question also.
Yeah, hi, thanks everyone. I'm based at Manchester and I'm a clinical psychologist by background. So I thought I worked with older adults, later life services, and I really liked how kind of, I don't know, thinking outside the box I felt this was, because we know that older adults don't access psychological services at the rate ideally they're, well, not the same rate as other people. Anyway, so yeah, I thought it was really interesting. Thank you. I guess my question, and probably with my psychologist hat on, is the idea then that like they'd signpost to psychological services? I know you mentioned social services, but I was just thinking, obviously, from a psychologist perspective, both in talking therapies and also in CMHT, that older adults are quite underrepresented, really, which seems like a shame.
Yeah, I mean, I think I'll answer this. I think signposting to NHS Talking Therapies is important, and often actually helping people, press on the right link and put the right information in.
Yes.
And I've certainly done that as a GP, because it's not necessarily easy. But I think more broadly, because we know that a psychological approach may not be acceptable for some older adults. So thinking about what's available in the community, is there immense sheds or, allotments, a cinema club? Yeah. So linking it with social prescribing community organisations. But I mean, what we're not developing is a psychological intervention for fire and rescue service to deliver. It's about identification and signposting.
And that's what I think is really nice about it. It's more of a focus of trying to make the options that are available, if you see what I mean.
Yeah.
I think Martin Webber's next with a question.
Hi, yeah, thanks. Really interesting combination of projects and approaches, and just wanted to reflect really on the, more particularly the review and the cluster searching method that you used. I particularly love the network diagram, which was really illustrative, I think, of how literature is hidden in this space. And really my question is around how you undertook the searching, and did you have any concerns about anything that was missing? Because obviously the kind of the search criteria that you might use, you don't necessarily know about them because you don't necessarily know where these interventions are going to be used, or how they're going to be phrased or termed. And I just wondered how you went about that, and you know, what are some of the kind of the strengths and limitations of the approach that you took?
Yeah, I don't mind taking that one. Yeah. So obviously that network kind of diagram was from Riddle. So with that particular study, I think we were acutely aware at the kind of start that a lot of the evidence we were going to be looking for probably wasn't going to be published in academic kind of databases and literature. But that's kind of where we started, I suppose, and then quickly found out that actually Google searches were probably just as productive, really, in terms of identifying some of those service level evaluation reports and things like that. So yeah, I think we've written about the kind of limitations in our paper. But I guess if it was a systematic review, I think we'd have more concerns about kind of missing out on potential interventions and reports and things like that. But I think for the basis of the realist kind of review approach, I think we had a sufficient evidence there to kind of base our theoretical kind of understandings and claims. But yeah, I think there's always a risk, isn't there, particularly with grey literature, that you're going to miss something kind of vital. Since that kind of project and during the kind of latter stages of it, we had conversations with kind of key stakeholders just to make sure there wasn't anything we were obvious that we were kind of missing as well. So I think we can be quite confident, but there's always that risk, isn't there, that you miss something pivotal or important, but hopefully we didn't. Hope that answers your question, Martin.
Ruth Mills has got a question next.
Hello everybody, I'm CEO of an Arts for Health design studio based in North Shropshire, and we work with quite a number of older adults, so I was really interested to hear the results of your research, and I've got two things I wanted to raise really. The first one was that the fact that there are a number of organisations like us that work with older adults, but perhaps the evidence base for what we do, although we see it working, does not exist. And in some ways, that's because of a lack of capacity in the voluntary sector. And in some ways, it's because of a lack of skill to carry out that work. So I wondered if, as part of this work, there'd be any opportunities to develop better understanding with voluntary sector services about why what we do works and how we can share, to use an art phrase, share the crayons with others.
Yes, please. I'll hand over to Carolyn.
Yeah, I suppose, yeah, as a team at Keele, we're very keen on working with community organisations and, you know, establishing an evidence base, because I think, as you say, Ruth, you see people get better, and I put in that in inverted commas, but you see people improve and engage and are less isolated. But there isn't an evidence base, and therefore commissioning is always on short-term contracts, very unstable, it's unsettling. So absolutely, we're happy to work with you in the future to put in another grant application to a funding body that might be receptive to this sort of work. And, you know, certainly, hopefully, NHR3 schools ticks that box. But thank you, Ruth.
Amazing. Yeah. We do work with a number of older adults, and I think the fact that we're an arts programme that isn't art therapy is more appealing to that group. Thank you for answering that question. That's really interesting. I'm also curious about the gap you found between social prescribing and help seeking, because we know there is a network of social prescribers, and yet we also know that the social prescribers aren't the individuals who are sending our older adults to us. So I wondered if there'd be any further investigation into that gap.
Yeah, well, we haven't got any work around social prescribing, but Steph Tierney and Caroline Mitchell have done some really lovely work around social prescribing and what they do and the benefits of, but also where the gaps are. And I think the evidence so far is that they may not be getting the most vulnerable, they may not be supporting the most vulnerable population. So I think more needs to be done in that area, but I think it's also about how social prescribing is sold to practices, and what's the is the benefit outlined, what do practices think social prescribers do, and I think that dialogue doesn't always happen. So often social prescribers or link workers are sort of parachuted into practices with no explanation of what they're for, and perhaps there's no trust on either side as to what the relationship is and what roles people have. So I think there's a lot of money being injected in social prescribing without good evaluation.
Thank you. That was really useful.
I think that's all the questions from the floor, unless anybody else has got anything else to add at all. I'm sure you all agree it's been fantastic from the trio. Very much appreciated, and hopefully see you all on the next seminar. So thank you, everybody.
Thanks very much. Thanks Claire, for the opportunity.
No
Lord
problem.
Sugar, as we say. Thank you, Lord Sugar, for the opportunity.
Thanks, everyone.
Thank you.